Okay, we're going to make a start on our next session. It's my pleasure to introduce Dr. Carla Nestor, the Associate Professor of Pediatrics and Director of the Division of Pediatric Nephrology in Iowa. She's going to speak to us about C3G and immune complex MPGN with some exciting developments to share with you over lunch. Thanks, Dr. Nestor.
Thank you, and I realize that we all are going to be trying to eat and actually hear at the same time, but one of the first things I wanted to say is, because this is a sponsored event, we do need to be careful about the kinds of questions that we field from the audience, so we won't be using the microphones, and instead, what we would encourage you to do is write down your questions. There are some cards on your table. If you have a question, just write down your question and flag your card, and someone will come by and grab it, and if it's industry allowed, then that's the question I will answer. Otherwise, obviously offline, I'm willing to answer some additional questions. So this discussion is really, it's sponsored obviously by Apellis. You all are aware of that. That's been flashed on our overhead several times here, but it's specifically we're talking about glomerulopathies driven by complement dysregulation. I moved very quickly through the C3G section this morning, in part because I knew I was going to be getting back to some of that here. But I'm also, perhaps won't address everything that I talked about this morning, but I want to also be very clear about adding the immune complex GN part. For some reason, okay, yeah, so first of all, the disclosures, as I've kind of already talked about, we are presenting the following from Apellis Pharmaceuticals, the content in the presentation and the views expressed therein, and those of Dr. Nestor are not from GlomCon and or Apellis. That's really the most important piece, because if I expound on something that is from my clinical experience, it's important for you to know that. The presentation is not part of the regular CME, and the biggest difference you'll notice about that is that normally when I stand up and give this type of talk specifically about the treatment, I am so pro alternative pathway blockade that I will talk to you about everything and anything that's ever been used in AP blockade, and I'm really going to in a very limited fashion do that, because again, I want to focus on one specific agent. And then finally, the information provided is for the educational purposes only and is not a substitute for your independent medical judgment. These, of course, are canned statements that we are required to share with you. And the last one being, there are no approved therapies for by the regulatory agencies for C3G or immune complex GN, and the safety and efficacy of, and also, by the way, you'll notice that I pronounce this even differently than the sponsor does. I say see, now I won't even be able to say it. Pegcetacoplan, I believe is how they pronounce it. I say Pegcetacoplan. Either way, it doesn't make any difference. You may hear me even say Peg, and I apologize to the sponsor, but hopefully they know exactly what I'm talking about here. Anyway, there is the safety and efficacy of Pegcetacoplan or any other therapy within the presentation for C3G, IC-MPGN have not been established. The real point is we have not had regulatory agency review of either phase 3 data or even, for that matter, peer review of a lot of these things. So let me just really start much more basic. So I want to give you a lot of background yet. And I've already given you the first statement that I do have disclosures, and I will say that in my lab and even in my clinical setting, we've been testing complement therapeutics easily and since 2010, and it started with SCR1, and some of you may know what that is, obviously, but we've had a number of opportunities to test in the complement field, and that's really where my clinical trial efforts have been ever since that time, essentially. So the objectives here, we're really going to review the basic structure and function of the complement system. We're going to discuss the role of the complement system both in C3G and immune complex GN. And then we're going to review the clinical manifestations and outcomes of these glomerular nephropathies. And then finally, we're going to discuss, obviously, that's one of the main points here today, will be to discuss some of the new exciting directions for the therapeutics. I often think about this as kind of my apologetic slide. This is my slide that tells you that we are really comfortable that complement, and particularly disruption of the alternative pathway of complement, is involved in C3 glomerulopathy. So the first way we know this is that the Yorkshire pig, which is a naturally occurring pig that, by the way, had a complement factor H that it could not get excreted from its liver. If you did a kidney biopsy on these pigs, you would find that they had, we called it DDD when it was first identified, but in fact it was probably C3GN. But the real point is the factor H being the major regulator of the alternative pathway, if it's absent, the alternative pathway is overactive, your animal actually has C3G. Then fast forward quite a bit, and actually Matthew Pickering from the UK created a laboratory model of complement factor H knockout. And this is in fact the animal model that most of many labs will actually use to study C3G, or to work around, if you will, with C3G. These animals actually have low C3s, and they have C3GN on biopsy. So they are very much like humans. Now, what about humans? Well, it turns out that the vast majority of humans actually don't have a genetic abnormality in their factor H or any other complement gene, and only about 21% of humans will actually have a genetic abnormality. So if you're trying to be terribly fiscal about this, you would go for the other potential driver first before you would actually go down the road of actually doing genetic testing. I'm happy to do a discussion about that later, because I am very pro genetic testing, but recognize that it's not the major trigger of this disease. And in fact, the majority of humans actually have autoimmune C3 glomerulopathy. And that means that they have either a C3 or a C5 nephritic factor as being the major drivers of their disease. You can see the other autoantibodies that I've listed there. I'm going to show you a cartoon of the complement pathway in just a moment so you can see where these fit. But really what I want you to see from this slide is that I think we're really comfortable by animal model and by human data that C3 glomerulopathy is caused by alternative pathway dysregulation. But particularly human C3G is not primarily a genetic disease. So now, because this talk is dealing with both C3G and immune complex MPGN, which Dr. Glasek will know, we really should call that IC-MPGN probably, because a lot of these patients may not actually have the membranoproliferative pattern, but nonetheless, IC-MPGN, it's what it's been called for a long period of time. And what is the animal evidence? Well, it's a lot more sparse, I should say. In fact, notice the date on the manuscript I'm actually going to show you here. And this is actually a rabbit model. And really, the way this goes in the IC-GN setting, if in terms of thinking of the basic science, is that if you get a very high exposure of antigen, and you know, this could be strep, but it could be other things. So very high exposure to antigen, you get an acute exudative proliferative glomerulonephritis, but you do actually get recovery from this. At least this is what this animal model would suggest. If they really blasted them with an antigen or a trigger, whatever it is, but then you get a really high immune response, you're going to get recovery. That's really where I'm going with this. As opposed to, if you really get, I'm going to say, a wimpy immune response, there's an immune response there for sure, and that's part of what's causing the glomerulonephritis. But if you get a more wimpy immune response in this animal model, that's the patient that got the chronic membranoproliferative glomerulonephritis. So this is only one of maybe 8 or 9 different animal models, but this is the one that I actually think fits the most for me in pediatrics. Maybe not so much in my adult population, but I mean, we could argue whether we really completely understand this. So now, what about, this is just one other animal model. Let's flip that over and say that if you get a low-level antigen exposure, perhaps you can navigate this by creating enough immune response to actually clear that antigen and actually allow that your glomerular injury will not be quite as great. That's at least what they saw in this particular animal model. As opposed to, if you really blasted that animal with antigen and you overwhelm the immune system's ability to clear it, you're still going to have the immune reaction, because that's part of what's causing the glomerulonephritis, but you don't quite have enough immune reaction to actually clear the antigen. That's the patient that actually gets this fairly severe animal that gets this fairly severe glomerulonephritis. I'm suggesting clearly to you that we don't know exactly what is the pathway to glomerulonephritis in the immune complex MPGN patients, but these two animal models, I think, give you a decent hint about how this can happen. But we know that, based on some much newer data than 1961, for instance, that C3G and immune complex MPGN are probably on a continuum to a degree. And the reason we know this is that it starts with both diseases are frequently preceded by an infectious event. That doesn't surprise you, and that is in fact why the complement gets activated, or why the immune globulin gets deposited for some patients. But also, as I mentioned to you this morning, the C3G immune complex MPGN biopsies are not quite as static as you might have believed originally. For instance, I mentioned Dr. Howe's work that said that 8% of the biopsies in the Columbia group went back and forth between immune complex GN and C3G. So that is a group of patients that you're not exactly clear, if you only have one biopsy in front of you, which of the two diseases you have. And to be complete, 16% of the French groups said the same thing. And in fact, in our registry, about 12% of our C3G patients, at least one time in their glomerular disease career, has had an immune complex GN biopsy. That's really the point that I want to share with you, is that there is some bouncing back and forth, and there may be a hint that that it could be a continuum where you present with immune complex GN biopsy first, but maybe it's something different the next time you biopsy. So just a little bit more about immune complex GN. This has also published data from the French cohort, for instance, that immune complex MPGN is equally as likely as C3G to have the underlying driver of disease. And I mentioned to you 21% are genetic, the other 60 to 80% are known to be nephritic factor driven. The point here is that immune complex GN is equally likely to have that underlying driver. And here's their presentation, and I know this is kind of small type for you, but I think you can see that if you run across there for their C3 nephritic factors, MPGN1, which is the older term, if you will, for immune complex MPGN, they had up to 53.6% of their patients actually had a nephritic factor, as opposed to, for instance, a C3GN patient had 45% of those patients had nephritic factor. So again, you're seeing that these diseases may have a little bit more in common. Take that one step further, and it turns out that they also noted that MPGN1 or IC-MPGN would be what we would call it today, or ICGNs, also had genetic abnormalities. This group tends to look for complement factor H and complement factor I primarily, not so much the other, factor B, et cetera, et cetera. So the point, though, really is that you're seeing that there were some genetic abnormalities in what we would call now IC-MPGNs or ICGNs. So the point is underlying complement, so you have a hint that perhaps targeting complement in both of these diseases actually might work out quite nicely. So let's think about, I addressed this very briefly this morning, that the burden of disease here is really quite high. Of all the glomerular diseases, it actually might be one of the highest, at least that's what our best estimate based on some of the cohort studies is. So 80% of children at ESKD by 10 years, 50% of adults. Now, I will tell you there are some cohorts that have actually flipped that completely opposite, but the real point for you is that the risk for disease is high. Then the risk for post-transplant recurrence is also quite high. And just a small caveat here for those obviously who are practicing regular nephrology, you may or may not know that C3 deposition post-transplant happens in a lot of patients. Just C3 deposition without proliferation or without significant membrane deposits, if you will, over the longer term does not represent disease recurrence. So keep that in mind, because it becomes important about when you decide to launch therapy. And then finally, those patients who do get transplant recurrence, very frequently, unfortunately, this is not a good scenario for them even in that setting. And again, these are patients who are on, in that particular setting at least, they're on calcineurin inhibitors, they're on mycophenolate mofetil, they may be on some steroids. So you're getting the hint that a lot of our standard of care is not going to be perfect in this setting. But then to close the loop on the immune complex MPGN patients, you can also see based on this Kaplan-Meier that it really didn't make any difference if your biopsy was IC-MPGN or it was DDD or it was C3GN. Your Kaplan-Meier was not pretty. Your risk for renal loss was still very significant in this group of patients. So again, I'm trying to make the case that it's reasonable to potentially lump these two together. You saw this morning, but I would like to go in and give you just a little bit more detail. And so this is KDIGO, Chapter 8. We released this in 2021. And this is, by the way, the name of the chapter was C3G, and I think the exact name was C3G and IC-GN or IC-MPGN, I'm not sure. But the point is that for KDIGO, we made no distinction between the two diseases when we were deciding how to treat it. So that's one of the first things I want to share with you. But then let's just sort of dig in a little bit. And the first thing was that, of course, you're going to do your supportive cares. You're going to do all the usual things that you would do for all of your glomerular disease patients. But then you're going to focus if that patient has greater than a gram of urine protein, and that was a number picked out of the hat. We can all agree that maybe 0.8 is better. Maybe 1.2 is better. We actually, frankly, don't know. We don't have the natural history data to actually support it one way or the other. But the point was, the group chose greater than 1 gram of urine protein or a sense that you had a more rapidly declining GFR, even if it was a 0.7 UPCR sort of thing. That's when you decided to add mycophenolate mofetil and steroids. On my next slide, I'm going to share with you why we decided that was going to be the treatment approach. But before I do that, I also wanted to mention, in 2021, you still had clinical trials available to you, for instance, and of course, in many places of the world, you would have considered eculizumab. And I will tell you, if you read the narrative for the KDIGO, you will say, well, you might try terminal complement blockade, but we can't be clear because we don't have clinical trials. Of course, that is really the point, and I don't want to say that KDIGO is recommended that we put all these patients on terminal complement blockade. So here is, I've collected for you 6 actually cohorts that actually informed the KDIGO, and this shares with you, and I've colorized this a little bit so that you can see that the red, even if you're standing in the back of the room, is supposed to represent no response to mycophenolate mofetil and steroids, and the dark gray or even near black, if you will, is to represent patients who went to end stage despite their mycophenolate mofetil and their steroids. So at the end of the day, you can see that the data was not perfect by any means, but in fact, it was at least enough for us to say that there were some patients that actually, you can see that there's enough green in this chart to say that if you're lucky and your patient does respond to mycophenolate mofetil and steroids, then in fact maybe they don't have that dismal 10-year prognosis. And so that is in fact why KDIGO decided where they were going to go with this. Not that we thought the data was perfect, and oh, by the way, you all know this is retrospective. The different centers use different protocols, meaning different doses of mycophenolate, different doses of steroids, et cetera. So it's really not even fair to even plan your day basically based on these cohorts, but this was the only data that was available. And then of course, as I sort of already gave you the preview, it's much harder to figure out what a good treatment plan should be for immune complex GN. or immune complex MPGN, because we don't know. There haven't been good trials to actually support what standard of care should actually look like in this. Because, for instance, it could make sense to you to use rituximab, right? If this is nephritic factor driven, or if it's an immune globulin driven period, regardless of whether it's technically speaking a nephritic factor, it may make sense to choose rituximab or one of its biosimilars, but we don't have data for that. So again, I think KDIGO recognized that, but needed to move forward with advice anyway. Because we did suggest the possibility of using terminal complement blockade, particularly in all those red box patients, I wanted to give you at least one of the cohorts. You're probably well aware that there are case reports that it worked, it didn't work, it worked, it didn't work, so it's a little bit back and forth. But this is one of the better or larger cohorts, and in fact, this is from the French group also, where they showed that they had roughly 12 of 26 of their patients got a decent response, either complete or partial. And it's a little too small for you to see, but these are patients that were already on close to standard of care. For instance, they might have actually been on mycophenolate mofetil steroids, or they might have been on cyclosporin and steroids, et cetera, et cetera. The point is, they were definitely on some baseline steroids. They weren't responding, so then they added terminal complement blockade, and at this point, at this time of this study, or this cohort, it was eculizumab instead of ravulizumab, of course. Importantly to notice for you, because I mentioned to you, I think I've mentioned to you multiple times that biomarkers are often not as useful as we would like. You may recall that there was a 6-person cohort published out of the Columbia group that the responders to terminal complement blockade were predicted by, if MAC was elevated in that group, then they were the responders. It turns out they got lucky in being able to predict, because if you go a little bit further, if you expand your cohort, then it turns out that MAC probably doesn't help you as much. Again, we could benefit from a bigger trial, of course, but really what you need to see here is that KDIGO felt fairly comfortable that if you're really not responding to baseline care at all, there may be another 40% of those patients that would respond to eculizumab. But even that's a very soft call, because there has been reported clinical response without histologic response. So you do have to be careful of that being something that's looming in the background for you. So let's now try to conceptualize a few pieces of this. And so let's go back to that figure of the complement system. And I share it with you. I know a lot of people actually hate the complement system, but if you think about the complement system, starts at C3 and it moves in a forward direction in theory to create MAC, and that's what its job is to create MAC, because that's what helps you, either making C3b along the way helps you opsonize things, or making MAC actually helps you destroy, whether it's bacteria, viruses, et cetera. So that's the complement system that we're really working with. But what I want to share with you is that yes, it's true that we start at C3 and we end at MAC, and that's the normal approach for your innate immune system. The major problem with those with C3G, and I've indicated may very well be with IC-MPGN patients, is that there is dysregulation of this pathway, particularly if you have a C3 nephritic factor or a C5 nephritic factor. So what happens is that those proteins glom on to these two major enzymes, the C3 convertase, the C5 convertase. Those proteins glom onto those convertases and they lock them together. In the natural state, those proteins should only last about 90 seconds. If you need more, you make more, but 90 seconds is really all you need to make enough MAC to help you get rid of an infection. Again, if you need more, you make it. In the laboratory, I have a patient, just as an example, I have a patient who has a nephritic factor, happens to be a C3 nephritic factor. Her C3 convertase stays active for 211 minutes. You might wonder how I can prove that, but it's on a surface plasmon resonance. I mean, it's an assay, yes, but the point is that she's not 90 seconds, she's 211 minutes. So you can see that not only does she risk making a ton of MAC, but she risks consuming her C3 because she doesn't have a normally regulated system. That's really where I wanted to go with that. It remains unclear to us. We don't have any data to suggest why excess lot of MAC being made is a problem in this disease. We don't know. So therefore, that's how we can't help you predict whether a given patient is going to be eculizumab responsive or not, because we don't know if the patient in front of you is, what part of their disease is actually driven by the terminal pathway. That's really the point. As opposed to an atypical HUS, many of you know that a lot of the disease is actually driven by the terminal pathway. It's much less clear in this setting. So really what I want to say to sort of summarize this slide is that it's not clear how much MAC is involved, but it is clear this piece, that if you have a system that is going and going and going, guess what? You are dropping a whole bunch of breakdown products onto your biopsy because you are cleaving C3 and you are getting complement breakdown products. So even though we can't say for sure how much MAC is there, we can say that an hyperactive alternative pathway is making way too many breakdown products, basically. That's really the point of sharing this with you. And I think that is why the alternative pathway, why the alternative pathway ends up being appealing. For instance, if I take this one step further, if I block right here, so you all know that terminal pathway blockade today, and today what's available to you off-label today even for this disease is that you know that if you block C5, you are blocking well below what the problem is in a lot of patients, for instance, if, for instance, they're driven by nephritic factors. I will be fair to everyone involved, and for sure, I absolutely love terminal complement blockade in a number of diseases that I work with, but in this setting, I'm less clear, number one. Number two, the science is not good enough to tell us who actually is going to be a good responder and who's not. So if mycophenolate mofetil and steroids and possibly terminal complement blockade are not perfect for you, then let me just use that same figure that I used before to share with you why someone might think about. I already gave you a hint. If the problem is further upstream, does it make sense to target further upstream? And I will tell you that now, based on these animal models that I'm going to share with you, that we even have animal model evidence that it makes sense to block upstream. So again, let's go back to thinking about, we've got that mouse model, and I mentioned to you that many of us will use that model. What if I take that mouse model and this time now I'm going to knock out C5? So that is, if I can be so bold to say, that's a mouse model. You've not only knocked out the major regulator of the alternative pathway, but now you've knocked out the terminal pathway. So that's akin to giving this mouse model terminal complement blockade. And it turns out that in their model, that C3GN that the mouse had, it got better. For sure it did. It didn't go away though. So that's my comment about partial amelioration of disease if you knock out C5. On the other hand, what if you knock out complement factor B? And the obvious reason for me to choose that one is because you all know there will be another sponsor that's doing something similar in humans, obviously. But in that case, you actually do knock out disease. So again, you have animal evidence that knocking out something in the alternative pathway, meaning right at that alternative pathway amplification loop, actually does help ameliorate disease. And then, unfortunately, I need to switch over to a rat model in this particular setting. But if you, and this looks a little convoluted to you, I'm sure, but the bottom line is that if you deplete C3, and they happen to do that with cobra venom factor, and we do that in the laboratory quite a bit, if you deplete C3, then you actually can clear the C3 deposition off of the kidney. Does that make sense? So if you get rid of the C3, you have no more C3 to actually create breakdown products, then the C3 deposition disappears off of the kidney. So that's a sort of convoluted way of saying that perhaps limiting the body's ability to cleave C3 produces potentially a remission and or, I'll use cure in quotation marks. So the point is that, again, with each of these, we have animal models to suggest that we could do better than what we are doing. Let me put it that way. This is normally the time where, again, it's already been said that, all of this is based on my opinion and my presentation. This is normally the time when I would go through and I would present to you all of the things that have been tried in this setting. But again, this is a sponsored session, so I'm going to focus on just one agent that actually blocks the alternative pathway, and it's using the concepts that you've actually seen us use here in this setting with these animal models, and particularly I'm going to discuss only the C3B blocker. So, hopefully you can see from my figure up here, if you block C3 or C3B, et cetera, you can see that you're going to block the alternative pathway. Particularly, you're going to block it at the amplification loop. So if you liked the animal models, it would suggest to you that you might actually get some success in humans. So I'm going to try, to be as complete as I can be. I went all the way back and just, I'm using publications for you to see. So, and you can, obviously you recognize from KI reports here, but this was the very first Apellis study, and it was a study in C3G patients particularly, and you can see that this was age greater than 16 years. The urine protein had to be at least 750 milligrams, and the GFR had to be greater than 30. The bottom line is that, and you can read across that a little bit more, but the point I think that is, oh, and I should also mention, many of you will know that Pegcetacoplan is a subcutaneous infusion. It's used twice a week. For instance, my patients will choose Monday, Thursday, Tuesday, Saturday, that sort of thing. Either of those is fine. But in terms of mechanism of delivery, basically it's, I don't know how many of you will do IVIG infusions at home, for instance. It's it's a subcutaneous infusion, so it's similar to that concept. If any of you who are used to doing IVIG at home, it would be something like that. But anyway, back to our study here. So we're talking about Pegcetacoplan. We're talking about a phase 2 study, so this was not placebo-controlled. I like that it went down to the age of 16. And it is, again, to re-emphasize, this is a C3B inhibitor. Treatment was for 48 weeks, and I'm going to skip forward because many of you, I mentioned this on the very first day that I gave a talk here, that we had a session where we tried to figure out what endpoints would be useful in this setting, and in the absence of really fantastic disease, what we came up with was proteinuria, GFR, and possibly a histologic finding, whether it was acuity, chronicity, or C3 score, et cetera, et cetera. But the real point to say to you here is that proteinuria is what the scientific community decided was going to be a useful outcome if you think about blocking the AP. That's really where I wanted to go with it. But the point here is that with AP blockade in these C3G patients, they got in an intention to treatment that, because it was a 48-week long study, they had some dropout. So that's what the difference in this is. But up to a 65% reduction in the urine protein. And I also want to make a step forward, because if I have time, I am going to go back and provide a real-world experience, if you will, of what happens to the biomarkers and when you use an agent such as this. But the point really here is, notice the serum C3 went up 666%. So these patients no longer have that low C3. And also the C5b through 9, which might have been elevated, is now going down. So this is their first approach, if you will, for attacking C3 glomerulopathy patients. And then, of course, it's very, very important to say that it was safe. I will give a small editorial comment here that when we started using complement inhibitors back in, like I said, 2010, 2011, or even when we started official larger scale clinical trials back in 2018, 2019, we worried a lot about what the infectious risks were going to be. As you all know, it's like terminal complement blockade. The infectious risks could be encapsulated organisms. So all patients entering trial must have good vaccination for meningococcus, streptococcus, and for the longest time, Haemophilus influenza. That may be changing right now, but those 3 encapsulated organisms not only had to be vaccinated, but up to date on, by the way. Anyway, we worried a good bit, I think, and this is my editorial here, we worried a good bit about the potential for infection in the beginning, but it's just not manifested in this 5-year time frame that we've seen. So back to my task here of staying on task and actually reporting out the second attempt for this group to actually address patients with C3 glomerulopathy now goes directly to transplant recurrence. So this is a pretty exciting study, obviously. So lucky for the transplant patients, it was 3-to-1 randomization, but the real primary endpoint was at 12 weeks. And so you were either Pegcetacoplan treated or you were observation for that 12 weeks. But then very nicely, and this is something that I've appreciated about many of actually the complement inhibitor trials, this one included, is this idea that everyone moves over to treatment. So at the end of the day, what they reported out was the results for some of the patients were 1 to 52 weeks, and for some of the patients it was 13 to 52 weeks. So, and this was called the NOBLE study. So again, I'll refocus. The first study was C3G native patients. This one is now specifically C3G recurrence. The more, I meant to say this to you, the more complete data set actually has been presented at ERA in 2024. So if you want to see all of the details of the NOBLE output, the 52-week output, you can actually go on the ERA site and actually get the full set of slides, I even believe. So, and so I'm going to go a little bit quick through this, but really the point is, and I know it's a little bit hard to see, but the bottom line is that the dotted line are those patients that were on placebo. These are the patients that were treated with Pegcetacoplan. These were the patients that were extended out to 52 weeks, obviously, and they were all, this is your completers, they called them. So these were the patients who were on drug the whole 52 weeks versus patients who might have had some break, if you will, in their continued treatment. But you can see that the GFR is definitely in this post-transplant group stable and possibly even improved, right? What about the biomarkers? And it turns out, because again, everyone does ask about the biomarkers in these studies, and let's start with C3 first. We already talked about the fact that if you weren't treated with Pegcetacoplan, you may or may not know that C3G patients generally do not normalize their C3, at least for 1 year. We can confidently say for 1 year, true C3G patients don't normalize their C3. So, and that's consistent with what you see here. As soon as you're given Pegcetacoplan or Pegcetacoplan, you actually do get an improvement, but particularly even out to 52 weeks, obviously, it's a sustained improvement. So that's important. But also think about the soluble membrane attack complex. Again, nothing happens if you're not on drug, but if you do actually block the alternative pathway, you do actually get some improvement in the terminal pathway biomarkers. And I'll keep it at that, saying it's simply a biomarker phenomenon. And then, of course, I gave you from the KI report the simple statement that it was a safe study, but I'll also say that NOBLE was actually also quite safe, and that really I can narrow it down and just very quickly say that there were no treatment emergent serious adverse events reported as related to the drug, but you can see that really not a lot of safety issues to worry about, and particularly the infectious issue is what we've all been very worried about from the very beginning. If you get a encapsulated organ infection, of course, that's going to be classed as a serious adverse event related to the drug. So that will be very important, obviously, for you to know as the background piece. But I would say that it was very satisfying that there were no treatment emergent events related to the drug. So again, we have a second phase of study with this agent, again, subcutaneous infusion twice a week, that would suggest that not only is it efficacious now in a C3G native group, but it's also efficacious in a C3 transplant group. So now let's take it to the last study, what's been going on for now, gosh, I want to say probably 3 years by now. I don't know. It's been going on a while now, guys. I shouldn't even say, but now it's called Valiant, and this is the phase 3, which we would all be waiting for. particularly this is very important for someone who practiced med peds. Now I can get down to the 12-year-old group in theory. You know, once, if FDA approval is received for this group, now I can reliably say I understand what I need to do for that 12-year-old patient, which I think is something that's going to be very important because this is a disease of young patients, young adults. Anyway, back to the point here is that we are 12 years old and up. Also importantly, C3G or primary immune complex MPGN. That's why I spent so much time at the beginning of this session, because I will admit freely, I was one of the naysayers. I was not, you know, back when I was in training, it wasn't clear what you know, caused IC-MPGN. Was it going to be the same as a C3G patient, that sort of thing. But anyway, C3G or primary MPGN, and now we also have pre and post-transplant patients. So this is the study that will have included all comers of the patients that you as clinicians in theory would want to be able to see. So it's a similar study of a lot of other studies you may have seen. So Pegcetacoplan treated patients for 26 weeks versus placebo patients for 26 weeks with the primary endpoint readout after that. I double checked with one of my coordinators. I think even though the trial was due to enroll its last patient, I think the end of October, we were given a dispensation, I'll say, because our patient had to be on vacation who was supposed to be enrolled, and they allowed her to come in 2 weeks late. So she was the very, very last patient that actually made it into the trial and then therefore made it past the 26 weeks. So we are now in a situation where we also have a phase 3 that has now begun presenting its data. And my talk changed completely yesterday morning at 0800 because there was a press release of the preliminary data for this phase 3, and it looks something like this. Let me just skip to this in that Pegcetacoplan met the primary endpoint. And again, I mentioned to you, in a lot of the alternative pathway clinical trials, the primary endpoint is proteinuria, so you wouldn't be surprised by that option. But anyway, Pegcetacoplan in their 63 patients, and again, this is the total, so this is IC-MPGN, this is transplant patients, this is 12-year-olds, et cetera. This is the entire group. They met their primary endpoint with a statistically significant relative percent reduction between the Pegcetacoplan and placebo at 26 weeks of 68.3%. And so, you know, of course, I'm biased because I've been in this trial, but I also will say that I've been in practically all of the C3G clinical trials, but this is a really, really impressive result. So let me go a little bit further and share with you some of the additional data. I don't have all the data. I only have what's publicly available, so that's what I'm going to share with you. We are also restricted because we have promised the ASN that they actually will get the bulk of this clinical trial data. That's Apellis's hope, is that they will have the rest of the work completed and they can be able to share it with ASN. But let's just move forward and now talk about breaking down that urine protein a little bit more. Still, we're talking about urine protein. C3G group versus the IC-MPGN group. And again, the point would be is because for those naysayers that aren't sure that these are actually close enough disease to actually get similar results, and you can see that actually the relative percent reduction for the C3G group was 65.9%, excellent p-value. The relative change for the IC-MPGN group was actually 74.7%, also excellent p-value. So I think that I think I might actually have one more group of proteinuria pieces of data that I can share with you. Now we're talking about the adolescent group versus the adult group. And again, these are important because you want to know that the treatment effect is similar across the patient ranges that you might need to be treating. And for instance, for the adolescent group, the relative percent reduction between Pegcetacoplan and placebo at week 26 was 74.6%, as opposed to for the adult group, 62.7%, all both with decent, well, I shouldn't say decent, very good actually p-values. So really what you're starting to see is some, I think, really exciting data. Now we need to dig in and as clinical clinical trialists or researchers, et cetera, we need to see the rest of the data and understand with complete details what's going on with them. But I think this is the last, a couple more slides with respect to the trial, but let's also dig in for the proteinuria in non-transplant patients versus transplant patients. For non-transplant patients, again, we're talking about a 67.7% reduction in urine protein compared to placebo, again, baseline obviously, versus transplant. And I think that this is also going to be satisfying for you to know that, again, these patients came in on usual transplant meds. I didn't mention that early on. Patients came into even the native kidney study on RAS inhibition, et cetera, et cetera. So, or mycophenolate mofetil, actually, frankly. They were allowed to be on a certain amount of the standard of care, not so much, high-dose steroids, et cetera, but you can see that it looks like these positive effects truly are consistent across each of the pockets of patients that you and I might actually have to work with. And then, of course, I should finish up by saying that the safety issues were actually quite fine. I haven't seen all of the safety data myself. I saw a summary statement, which would have been, in the news release, et cetera. As investigators in this trial, each of us will have to dig in and figure out whether we appreciate all the data that's going to be made available or not. I don't know, but and this was actually just the final. And I can just unwrap this completely, but the point is that all studies have secondary or primary and secondary endpoints, and so you can see right away that they had statistically significant meets, if you will, for at least two others of their secondary endpoints, and again, some really, really nice data, I think, and I was so very fortunate that I got the chance to share this with you because I did not even know this data yesterday. So this is actually great. Now, I'm going to finish up. I have roughly 4.5 minutes here. I'm going to finish up by sharing with you a real-world experience. And part of it is because you all know, or I've said more than once maybe, that I work in a biomarker lab. What I do is lots and lots of biomarkers, or understanding drivers of disease and what drivers cause the biomarkers to do. So I wanted to present to you a patient, which I'm allowed to present because I can see the data. This is a patient who presents to me, and maybe I can share with you that, first of all, C3 very low. Our lab we call 90 normal, so 11 C3. This was not acute. This was a C3 that had been that way for at least a year. You can see other things other findings here, that the C5 was very low. So this is a pathway that's going and going and going. We are consuming products. C5 has been consumed. The APFA is quite low because you don't even have enough C3 to make the APFA assay work. And I think you can see that the nephritic factors, this patient unfortunately had the circumstance of having both moderate grade C3 and C5 nephritic factors. That's really what I wanted you to see, is not only what the patient's biomarker panel looked like, but also where that fits into that pathway, because I think it can be very useful for you, because one of the comments you're going to hear me make regularly, whether it's here or at ASN or at ERA, wherever I am, not all complement inhibitors are going to be made alike, right? So I think there's going to be a need to think about this from a precision medicine standpoint to a degree. Anyway, let me get back to business here. So you can see this is a pretty yucky biomarker panel for this patient. Now, if you treat this patient, I think these are data, I believe this is treatment after probably about 8 months of therapy, I think. But if you treat this patient, look what starts to happen with the biomarkers. A C3 of 11 is now 285. A C5 that was very low compared to normal is almost doubled and is now very close to being normal. So you're getting a hint that not only are you able to replete the C3, which, from a basic science standpoint is like that rat model, right? If you're able to replete the C3, you might be able to improve the biopsy, right? That was really the point. But I really wanted to get you to catch this issue too. There is nothing about the current complement inhibitors, this one included, that is going to do anything to the nephritic factors. That probably makes sense to you, right? Nephritic factors are a B cell phenomenon. They're not a direct complement pathway problem, right? They cause a complement pathway problem. But guess what? It seems to be okay that if this patient has both a C3 and C5 nephritic factor, if you block the pathway right here, so essentially you make this entire part of the pathway not work, then in theory you don't get the deposits, and you don't get any part of the disease that we talked about earlier that may be related to the terminal pathway. So many of you might say, well, so what? These are biomarkers. I told you on the first day, we don't know what biomarkers mean. You're right, there's a lot we need to know about biomarkers yet. So let me share with you this patient's clinical story that was collected at exactly the same time that her biomarkers were collected. So when she presented, she had a hemoglobin that was on the low side. She had a urine protein that was 7.6 grams. Her creatinine was okay. It was 0.58, so that was okay. So that is consistent with this set of biomarkers. These are her clinical biomarkers now. And again, they are consistent. When we created this, we picked them to be exactly matching this set. So now we have a urine protein that is normal in our lab, or most labs, less than 0.2. Creatinine, I would say those are pretty much the same creatinine, but I will offer to you, this is a pediatric patient, so the difference between a 0.58 and a 0.42 may actually be real, but nonetheless, you can see that we have a substantial improvement. We can talk about GFR in children at another time. You know that children, the GFR estimates are probably not great, et cetera. So I don't really think that she's necessarily got the difference between 104 and 149 millimeters per minute of GFR change. I don't know that. But the real point to offer you is this is a real world experience, if you will, with using an agent that blocks C3 or C3b, blocks the alternative pathway, and what can happen to the biomarkers and actually what can happen to the clinical parameters. And that is outside of this clinical trial. This is just me sharing with you some of the things that we are looking at in our lab to try to help you understand who's going to respond, who's not going to respond. If they do respond, how do you measure it? How do you find it? That sort of thing. Thank you. And I didn't give a lot of time for questions, but I will take some questions if people would like.
Thank you.
We technically have to have them on those cards, unless somebody wants to supervise that. I don't know.
Thank you so much for all the excellent talks, Dr. Nestor. It has been very wonderful to hear all those compliments, talks and everything. My question is when we do the studies, how many, a portion of the patient who are refractory or not responsive to eculizumab, do we include a lot of those patients in the study and then to see how they respond, after getting the new medications?
Yeah, maybe I didn't catch all of it. So how do we tell the difference? Say it again, one more time.
Yeah, so if I'm not mistaken, you included pretty much everyone who received a standard immunosuppressive medications to control the C3G. And I wonder if you included any patients who got eculizumab, and then not responsive to the therapy. Is there any portions of study populations that are included?
Yeah, so I will say that in these clinical trials, and the reason I can't answer this, I think Apellis is okay with this, but the reason I can answer this one is because it's not about the drug, it's about eculizumab. But for this clinical trials, any of the clinical trials, they could not have been on complement inhibitors, and so none of the patients that have gone through these studies have been on complement inhibitors. Or if they had been on complement inhibitors, they had to have been off for enough time. And again, I'm forgetting the actual inclusion criteria for this study because it's quite, in my experience, and I would say we've enrolled, probably about 28 patients into, these clinical trials, if you will. None of them could be on, have had active eculizumab on board when they went in. And I don't know the answer to the question about whether they were non-responders or responders to eculizumab. I would say that if anybody out there enrolled someone who had been on one of these agents, they wouldn't have enrolled them had they stayed responder, if you will. Just because we're so early on in the decision tree, if you will.
Yeah, thank you. Because, I'm one of the transplant nephrologists from Mayo Clinic. And then we do have those patients who has a recurrence, after transplant. And then all those patients, they got all the lymphocyte depleting agents. They are on full immunosuppressant medications. And then eculizumab work in 50% of the time, but not all the time. And then most of those patients, they are very young. And if you lost the kidney from the recurrent C3, the center will be reluctant to, accept you as a second kidney transplant agent. So I would be very fascinating to know if this new medication would have any role for those patients.
This data would suggest that it would suggest that it would help all comers with C3G who recurred post-transplant, whether they had been on MMF, whether they had been on whatever the other agents were. Even I would guess if you, because I can say this independent of this drug, I'm not a big fan of terminal complement blockade in this disease because most of my patients are driven by nephritic factors. And even if you block the terminal pathway, you're not blocking the function of the nephritic factors. And my personal bias is that you have to block where the nephritic factors are causing the problem, or where the C3 gene mutation is, or where the factor B gene mutation is, that sort of thing. I would suspect that these sorts of things, and again, it's all theoretical now because we don't have an FDA-approved option for us, but and maybe that's the best way I should leave it is that we don't have a trial that says if you are eculizumab non-responsive, will you respond to Pegcetacoplan? I don't know.
But thank you so much for your answers.
I can guess later for you. How's that?
Sounds good.
Okay, maybe just a quick question. So does the drug block at both the C3 and C5 convertase, and is the degree of blockage, is it preferential between the two, or does it predominantly block one or the other?
Yeah, if I understand the question, it's a little bit of a misnomer to create the cartoons the way we do. It's probably the exact same C3, the exact same C3b that goes into the C5 convertase that goes into the C3 convertase. We write them as two completely separate entities, but they're probably not really two completely separate entities. It is true, though, that the nephritic factors are recognizing something slightly different. So they do actually recognize two separate things, but it may be on the same molecule, just recognizing, for instance, the C5 nephritic factor may be that it only recognizes the convertase if you add that extra C3b. So it's not, it should not be a dose problem. That's where I really should go with it.
Thanks, Carla. Great talk. I'm sure this question has occurred to you, but by analogy to diabetic nephropathy, it would seem that combination therapy might be a very logical step going forward. Distal complement inhibition and proximal complement inhibition simultaneously, attacking two aspects of the disease.
And here I thought you were going to ask me, what I thought you were going to ask me is, why don't you get rid of the nephritic factors?
Right. Yeah.
Right? Because that's the, because, for instance, the BAFF and APRIL, would that work on getting rid of nephritic factors? I think that the hope for us, and again, this is a generic comment about whatever agent might be blocking AP, the hope for us would have been that if you block the AP, you don't need to also extra block the terminal pathway.
Yeah.
Because if you'll notice in this patient, when you blocked her AP, her terminal pathway went quiet. Okay. So the hope is blocking the AP will get you where you need. But again, that needs to be proven. I still think we need to get back to the issue of getting rid of the nephritic factors. Rituximab doesn't seem to do it. Bortezomib doesn't seem to do it. I know that Brad Rovin has published you can get rid of some factor H autoantibodies, which is also a problem potentially in this disease, but we've not seen anybody be particularly successful about getting rid of the nephritic factors. But for me, that would be the dual therapy approach. Tackle your nephritic factors with something, all the while you're protecting the kidney with a drug like Pegcetacoplan, potentially. Thank you.